we will discuss about pain management today. Mainly we will focus on clinical applications. We know that in pathophysiology, mainly pain is carried by A delta and C type of nerve fibers. So this is one important aspect, and there are numerous neurotransmitters involved in pain. For example, substance P, CGRP, and some positive neurochemicals. This is some basic in pain pathophysiology. Coming to the treatment proper, we can divide it like this: mainly acute pain, chronic pains, and neuropathic pain. And for acute pain management, we know that we can utilize NSAIDs. And clinical importance of these NSAIDs is, these are very good medication in controlling pain as well as reducing inflammation, except for paracetamol, acetaminophen. So we can utilize them in acute pain management. But as majority of you might be knowing, some of the major adverse effects of NSAIDs are gastric irritation. But the thing to remember here is, this occurs mainly with aspirin. So when we are using aspirin, we can focus on the gastric irritation, and if the individual is at risk of developing gastric ulcer and all, we have to avoid aspirin. And one more thing is renal impairment, renal injuries. So this occurs with NSAIDs when the individual is at risk of developing volume depletion, like intravascular volume depletion. Suppose the patient is taking diuretics for some medical condition, then there will be chances of depletion in the intravascular volume. So such individuals are at risk of developing renal injury. Then we have to know that these NSAIDs can also increase blood pressure. So these are few things we have to keep in mind. And among NSAIDs, gastric irritation is mainly because of aspirin. So other NSAIDs can be utilized, and we know that acetaminophen has lesser side effects, but the problem is it doesn't have anti-inflammatory property. So we can utilize other NSAIDs. But when it comes to selective COX-2 inhibitors, for example, celecoxib. So here the side effects which we have mentioned might be lesser when it comes to selective COX-2 inhibitors, but cardiovascular adverse events are more common with COX-2 inhibitors. Then some long-acting NSAIDs like naproxen. So here these cardiovascular adverse effects are very less when it comes to naproxen, but the risk of GI irritation is comparatively higher with naproxen. So these are few points about NSAIDs. Then what about opioids? When we use opioids for moderate to severe pain management in acute as well as chronic, we are worried about dependency or addiction to opioids. But the thing is, majority of the physicians will not give adequate dosage of opioids because of this inertia. Remember one thing, dependency and addiction with opioids is rare, but there might be chances of tolerance. So addiction is actually rare if the patient follows physician's prescription properly. Addiction is rare, but there is chances of tolerance. That is, the individual might require higher doses as the days progress. So this might be a problem. And when we think of opioids, we are again worried about adverse effects of opioids, mainly sedation and constipation. So to prevent these things, what we have to do is, to prevent sedation, we have to utilize extended release form of opioids. Some will come as transdermal patch, for example fentanyl, transdermal patch of fentanyl can be utilized so that it will maintain a sustained level in the blood and it will not cause dependency and sedation. And what about constipation? This is a universal adverse effect of opioids. So for this we can utilize opioid antagonists such as naloxone when we need opioids for pain management with no other option left. So we can utilize naloxone to handle constipation. Then what about respiratory depression? Usually respiratory depression will not occur with opioids unless we combine opioids with benzodiazepines. So respiratory depression occurs only if combined with benzodiazepines. So here we have to monitor for respiratory rate. Mainly there will be bradypnea when it comes to respiratory depression. So the overall point about opioids is these are really good medications when it comes to moderate to severe intensity pain management. So we can utilize these drugs properly. Side effects are universal, but majority of them can be managed, and addiction is rare. And few more points are mainly these will act through mu receptors. And what about combination of opioids with NSAIDs? These when combined will have additive effect. They will act very well and the systemic side effects will be lesser because when we combine both, the required dosage will be reduced automatically. So the adverse effects will be lesser when we combine both. Now to discuss chronic and neuropathic pain, why we are discussing both together is chronic pains will usually have some emotional component. For example, mainly it will be associated with depression. Reasons might be numerous. For example, even cancer pain or post-herpetic neuralgia, even chronic migraine. These are few reasons for chronic pain. And when we deal such chronic as well as neuropathic pain, we have to not only focus on pain management, simultaneously we have to treat these emotional component also. So what we can do for this type of pain is, we can utilize few medications like tricyclic antidepressants or SSRI or SNRIs, even some anticonvulsants. You might be knowing diabetic neuropathy, we commonly use pregabalin, gabapentin, nortriptyline, duloxetine, etc. So we have to know few clinical concepts about these medications. When it comes to tricyclic antidepressants like amitriptyline, nortriptyline, SSRIs we can consider duloxetine, and anticonvulsants we can consider carbamazepine, pregabalin or gabapentin. Here the important points are, tricyclic antidepressants are very good when it comes to control of neuropathic pain, but the problem is mainly sedation. So the individual who is elder or the one who is involved in continuous mental activity, we should avoid using tricyclic antidepressants. So mainly sedation and some cardiac arrhythmias might occur with tricyclic antidepressant, whereas these adverse effects are lesser when it comes to duloxetine. So we can utilize duloxetine in such individuals. But the thing is, the efficacy is comparatively lower when it comes to SSRIs. What about anticonvulsants? We can use pregaba or gabapentin, carbamazepine, etc. But the commonest side effect is sedation again and giddiness. Some GI trouble might occur. So we have to keep an eye on these adverse effects, and we can utilize combination of these medications. For example, pregabalin plus duloxetine can be utilized when it comes to neuropathic pain such as diabetic neuropathy. So the overall summary about pain management is we can utilize NSAIDs, but careful in prolonged usage. So we have to monitor GI side effects, mainly GI ulceration and bleeding. And it is more common with aspirin and naproxen. Other NSAIDs we can utilize. Selective COX-2 inhibitors will lead to cardiovascular adverse events. So we have to be careful. When it comes to opioids, side effects are common, mainly constipation, but if there is compulsion to use opioid, we have to manage these adverse effects with antagonists such as naloxone. And remember, opioids will rarely cause addiction, so we can utilize them at right spot without any hesitancy. When it comes to neuropathic pain, we can use SNRIs as first-line agents. For example, duloxetine. We can consider tricyclic antidepressants such as nortriptyline, amitriptyline, etc. But we have to keep it in mind that these will lead to severe adverse effects such as giddiness, sedation, and cardiac arrhythmias. So we have to individualize the medication according to the patient's profile. And one more important thing is, when it comes to neuropathic localized pain, we can use lignocaine patches. 5% lignocaine patches can be utilized for localized neuropathic pain. There are numerous other modern therapies for pain management such as intrathecal injections, regional spinal analgesic medication delivery, etc. But to be practical, we have to know about NSAIDs, opioids, and neuropathic pain management. Hope it helped. This is all about chapter number 13, pain management of Harrison. For more such videos, subscribe to our channel, share it among your friends. Thank you.